everyone. Thanks for tuning in. This is Joanne Sark. We're over at the office at Hawaii Public Health Institute. And I'm so excited because I have my friend here, Dr. Tlesla Adams, and someone I met through Dr. Emma Aluli, who was a great mentor and friend to mine, as well as to Dr. Adams. Anyway, he has lots of interests. He's been involved with our Hawaiian Kūkākūka through the Pacific Regional Indigenous Doctors Conferences. And we learned so much from him. I'm gonna just read this because I don't wanna mess it up, but he is from British Columbia. And I'm gonna let him tell you a little bit more about his personal history, but is completed his doctorate at University of Calgary. And then also from Johns Hopkins University, he did studies there. Also, he was a Deputy Provincial Health Officer for British Columbia for a couple of years in 2012 to 2014, and Chief Medical Officer of the First Nations Health Authority, and then Deputy Chief Medical Officer of First Nations and Inuit Health Branch, Indigenous Services in Canada, most recently. And I know he has a new post, which I'll tell you about. But mostly when I try to describe Evan to others, I just said, you know, he's the bomb in Indigenous public health. And as somebody who's had a career in public health, I always like to hear and see and learn from others and through the lenses, especially of other Indigenous communities, to just enrich us and let us look at different perspectives. And so he's in town and I wanted to share him with all of you and hear a little bit more. Thank you for those who also posted questions. I appreciate that a lot. I'm going to hand it over to you, Evan.
Thank you, Joanne, and thank you for arranging this. And I'm sure there are others, like Kat, who helped with getting me here. It's really a wonderful opportunity, and I'm so happy to present some ideas to you. I'm going to try and say less so that I say more today, and I hope that there'll be some time for some discussion. Indigenizing public health, being in the circle of care of public health, looking after each other is such a time-old tradition that I'm really proud to be a part of. And I'm really proud to be with a leader like Joanne, who's been in Indigenous public health for longer than me. I started public health later in life. And of course, the way you do public health here, your area of expertise, not mine. I'm just learning about public health in Hawaii, but indigenizing public health and the way public health is done here is different than in my home in Canada. So I'll just be really clear. I'm here as a humble learner, but I also want to share some ideas, and probably a lot of what I'm saying you'll know, but I'm just saying it in a different context. Public health really is traditional work. Our people looked after each other, looked out for each other, planned for each other. And so this kind of modern discipline of public health is a bit confusing. It's maybe a bit of, say it this way, it's a bit of whitewashing of what we've always done. And I'm constantly trying to decolonize public health. But let me start in a proper way. Aje chepotans je aje, imutaf rananape, imutaf kwalna tanapesht. I'm so happy to see you all. Thank you for having me here amongst you. Tlesla Adams. My name is Tlesla, one who is strong. And I'm from the Salish-speaking peoples, which is in the Pacific Northwest, Seattle, Vancouver area. There are about 50 Salish-speaking villages, and that's where I'm from. And in my province of British Columbia, Indigenous people are very powerful and they run their own health systems. So I'm from an organization called the First Nations Health Authority. It has about 1,000 staff who look after about 200,000 Indigenous people. And my department is the public health department. So that's where I'm speaking from. So if we could, oh, she's going, there we go. There's my first slide. And these are some stone masks that were collected by one of the heads of the Department of Indigenous Affairs. And he separated them. He sent one to our national capital in Ottawa, he sent the other one to the Louvre in Paris. they fit inside each other. They're meant to be together, but they were separated for over 100 years. And to me, it just represents ideas that you need to be together and not be separated. And let's go to the next slide. So in Canada, we're facing, well, we just had a Truth and Reconciliation Commission. For those who don't know, the Truth and Reconciliation Commissions around the world, they were in Chile and Argentina, looking at collecting first-person accounts of state-sanctioned human rights abuses against part of the population. In Chile and Argentina, it was against political dissidents. In South Africa, their Truth and Reconciliation Commission was about state-sanctioned human rights abuses against people of color. And in Canada, they were first-person accounts of state-sanctioned abuses against Indigenous children through our residential schools. And we're discovering today, after the commission finished, that there are tens of thousands of unidentified children in graves in those former residential schools. And so Canada is facing, first of all, the cruelty of that time that people have been poo-pooing for a little too long, that we have to repatriate those bodies and try and identify them, so send those children's remains home, and that Canada has to deal with its colonial past. As much as they've said, oh, well, it happened, everyone get over it. It is a very bitter pill, and we're sad of those the discovery of those child bodies, but also really angry. So how do we do? So that's the current issue that everyone's thinking about now in our country. Go to the next slide, thanks. And in our way, we talk about our positionality. Where am I working from? You know, I'm a man of a certain age from Canada. I'm different probably from you. I come from you know, a different ethnicity, but also from a different geography than you, but we have some commonalities in our stories. And I think it's important to say that my work in public health, trying to help communities have better health services, really is a very deeply felt one. When I was a little boy, and this is a photo of me with my 4 sisters, one of my sisters was in a very tragic accident, and we were waiting by the side of the road to see if the ambulance would really come, because we'd only just started the ambulance service coming to our community. There used to be an ambulance service, but it was for white people. It wasn't for us. And so when my sister was hurt, we were waiting and waiting. It was very traumatic to see if anyone would help us. We were just children standing by the side of the road waiting for help. So it's no mistake that this is where I work. Next slide. And this is where I'm from, British Columbia, in case you're not clear on the geography in the Pacific Northwest. There are, in southern British Columbia and northern, northwestern United States, Salish-speaking people, those 50 villages. And my people on the Canadian side, one of the very important part of our colonial experience is that we don't have treaty. We never ceded our land. And that historical fact gives us a legal loophole to claim these vast pieces of real estate. And of course, with real estate, you get political might. And so our province, our First Nations people, including with other pieces of legislation like the UN Declaration on the Rights of Indigenous People and other pieces of legislation, means that we're well positioned to have a voice in our own lives, in our own bodies, and what happens to them in our own health services. Next slide. And here's a representation of Indigenous people in Canada. We're significant. We're significant. In the northern part of Canada, we are 25, 50, 80% of the population in those areas. That gives us tremendous might. And so as you travel north in Canada, you will meet very powerful leaders who reign over these enormous tracts of land, hundreds of thousands of hectares, and end their mineral rights and water rights and animals and plants and the like. And of course, they're circumpolar, which are strategically important, so they are supported by our federal government. But so that's a very important view, because sometimes when we portray ourselves as Indigenous people, we're often marginalized, we're small, parts of the population were non-dominant in our culture, in our countries. And that's sometimes true in Canada, but very often it's not, especially as you go north. Next slide. Here's a beautiful island in my territory. It's called Ayus, and Ayus is like a long, thin island. And if you cut it along its long spine, one half is in private ownership, about 3,000 tiny pieces of land where there are cottages by the sea, and the other half still belongs to us. And our side is completely undeveloped. Not even a tap, there's not even a concrete pad, there isn't a place to land your boat. And we're very purposeful in doing that. We wanted to preserve, because the other side of the island is actually profoundly overdeveloped and incredibly expensive. And I know that metaphor will ring for you here in Hawaii. And I remember presenting to some doctors, and one of the doctors said, "We really want to help you develop your side of the island." We said, "No, yeah, thanks, but no thanks." That's not our viewpoint, but I like the metaphor of things. So we've been, in our lands for a long time. We keep resetting our archaeological timelines. Before we used to say we've been here for 4,000 years, and then it was 8,000 years, and then it was 10,000 years, and then it was 13,000 years, and now we're at about 18,000 years that we've been in our lands. And in fact, one of the oldest archaeological sites in North America is like a few hundred feet from my house. It's we've been here for a very long time, and that's so important because so for instance, and I'll tell you this story, we're renaming the local area. We're taking away some of the English names and giving traditional names. And some of the people have said, well, we've been here for quite a long time, like 35 years, and we have a say now in what these places should be called. And we're saying, no, 35 years, 13,000 years, like how? I don't know on what planet that's comparable, but from our point of view, 100 generations is different than half a generation. Next slide. And here's a photo of my great-grandfather. His name was Atum. And he's a survivor of the smallpox epidemic. And he didn't die. Smallpox is a notorious killer. It kills about a third of the people that it infects. Probably more in our population, because quite a number of us died, but more than a quarter. But for some of the people it infects, it blinds them. My great-grandfather was blinded as a baby from smallpox, and a physician took a picture of him. So in this photo, this is about 1930, almost 100 years ago. He was 70 at the time, and he used to cut wood, a blind woodcutter, if you can imagine. He would feel around in the forest and take his little handsaw and cut pieces of wood as an old man and sell that wood. And so when I feel sorry for myself, and this is important because I felt sorry for myself during COVID, I try to remember him. Next slide is of my grandmother. The little girl is my grandmother. This is my father's mother. She lived to be 15 and then she died. She had a single child, my dad. And this is the only photo in existence of her and it's of her as a toddler, basically. But that tiny little life of hers, being 15, pregnant, has a baby, she's skinny because TB is a wasting disease. It takes a lot of energy to fight that infection. And then she passes away, but we're here, but I'm here, is an important part of our story. The next picture is of my mother in residential school. My parents met in residential school. My mother was taken when she was 5, and she stayed in residential school until she was 18. My father was on the run, and he wasn't caught until he was 15. In my dad's mind, he was a man, and my dad was very athletic and very like uber butch. That's the only way to describe it, like uber butch, like literally a boxer. And when he was 15, and they would try and humiliate him in school, he would not be subjugated. He would not be subjugated. And that's a really important part, because when him and my mother married, my mother didn't know how to cook a fish. And this was shocking to my father, shocking to my father's grandmother who raised him. And my father said, you know, when I was growing up, because he really had strong gender roles. My mother had the girls in the house. I was outside with him. I was not allowed in the house to do housework, and the girls were not allowed out to hunt and fish with me and my dad. But he insisted that I learn how to hunt and fish. He said, I don't want you to be useless and ignorant of our lives. I don't want you to be so stupid that you don't know how to do simple things. He was very firm, and he would be challenged by the local school. I remember a teacher shouting at him. She didn't know who she was talking to. She said, you know, by law, your son is supposed to be in school. My dad would pull me one day a week. He would pull me out of school. And he swore her up and down and said, how dare you tell me how to raise our children, because we have a way. Our way is, you know, children are raised like this, and you know nothing at all about how that works. So don't speak to me again about what my son needs. And he was firm, and I had no idea. I thought my dad was crazy. Honestly, I thought my dad was so mean, and you know, he would make me hunt and fish. I would sleep on the beach between the logs with just a coat to cover me. We would make a fire. We would just bring matches and a knife, and it was you know, I just want to sit on the couch and watch TV. But he was very firm, thank goodness. Next slide. And my dad was an athlete, and it wasn't, the pursuit of athletics was not the point. It was that he was just strong, because that was what you were supposed to be. You were supposed to go out on the land. You're supposed to catch your own fish. You're supposed to be, if you're a man, be strong and do the things expected of a man. And he was very clear about his role, and he would say, don't let people hurt you, because at some point in your life, someone will try and steal from you, someone will try and hurt you, someone will try and hurt your family member. So he said, be ready. One day you will have to fight for your existence. And he said, and it's not for the point of fighting. I'm not teaching you to be violent. I'm not teaching you to be mean. I'm not teaching you anything except that the world is like this, and you must defend against the world. And so he would say, just in simple things like school or sports, he would say, just stick up for yourself. If someone is racist or mean or lousy or a bully, ignorant and stupid to you, push back, because that's what you do in life. You don't let people do bad things. So he was clear, and so he would make me, and I was a little, like, I'm very small, like physically, and I'm gay, and I was a very feminine little boy, and he would say, you stick up for yourself. And so I would. Next slide. These are important kind of transmissions of knowledge for me. He was very clear, don't step on me, I will bite you. And that was part of our teaching. It was so bizarre to me, because I didn't hear stories like that anywhere else in the world except from my dad. And now that we're older and we speak to young people and remind them of our ways and say, you know, those old ways, they actually had value. When I was growing up, they had no value, but it was the only thing I was receiving from my dad. My job is not to make things up that are so sweet they can't be true, but to tell you what he actually would say. And that's what he said. He said, it's important for you to seek justice and fairness in the world. Next slide. And so in BC, with our political and economic might, we have said, we are not going to be invisible in our own territories. In fact, to give you an idea, we met with the dean of the School of Medicine, and the dean said, we would really like, as a university and a place that trains doctors, we would like to help you, Indigenous people. And the chief said, your school is in our territory. It would be nice if you did something helpful. And he put it in his place. And then the dean had to say, we will try harder. And so this is very much how the chiefs work. And I don't know about governance or leadership in Hawaii. I'm very interested in that subject. I know Joanne is a leader, and I think that I think expertise and those who work and those who support leadership are leaders as well. And so how do we talk about that? So we have literal chiefs at home, and they're very interesting to look at, but chiefs are not necessarily health leaders. Like, who's in charge of the people? Who's looking after the people in the way that we're accustomed to looking after the people? It's different than a chief's vision. Next slide. And it's really about the circle of care. The red, there we go. The circle of care. The circle of care around us used to be all brown people, dark people. And then for a long time with colonization, it was all white people around us looking after our affairs. And now we're switching back. So how do we insert ourselves? How do our leaders insert their people into that circle of care? And how do we take that place in that circle and say, I absolutely belong here, looking after the people? Yes, there are important doctors and nurses and hospital staff and government staff and all of that, but we're the real deal. I think of, it's a gay reference, Gentlemen Prefer Blondes, and how Jane Russell was made a lot more money than Marilyn Monroe, but Marilyn Monroe said, but I'm the blonde. And so that's how I see it. Is, you know, I go into a room and it's all non-Indigenous people, all leaders, all fancy doctor, physician leaders. And I'm like, I belong here because I look after my people. And so that assumption, or taking one's place, is something I wish to talk about with younger people. And as an associate dean in a school of medicine, this is an idea that I take very, very seriously. Next slide. So here's some background around Indigenous people in Canada. Here are some seminal reports, probably the ones that are more recent. Like there's a listing here from the 60s, there's one from the 90s, maybe those are less important than the ones from 2015 and 2019. So if any of you are wanting to read around some of what I'm talking about, there it is. Next slide. But some of our most important work is around murdered and missing Indigenous women. I worked in the downtown east side with marginalized Indigenous women for about 5 years. And it's amazing and it's terrible how many men are invested in the degradation, control, and power over Indigenous women. It's really quite revolting. And so it's not surprising to me that some Indigenous women are fodder for terrible men. And we always talk about, how can we protect women? It's very clear to me that we need to do something about men who live for the degradation and exploitation, who live off the backs of those women. They are very strange creatures, and we don't talk about that. This report talks about these poor, marginalized Indigenous women who deserve better lives, and it's a really excellent report. Next slide. One of the seminal cases in Canada is Joyce Echaquan, an Indigenous woman who was berated, and she recorded this and broadcast it on Facebook. She was berated as she lay dying, and she eventually passed away. I can't remember her diagnosis, but her broadcast of how the hospital staff were being racist and swearing at her, and they called her terrible names as she lay dying, and that led to some reckoning of particular medical staff, and particularly implicated were a nurse and an orderly. And so for those two professions particularly, they talked about how many of our members, how many other professionals are exactly like this worker, or was, you know, the worker who was caught on film just doing rub-a-dub everyday workplace racism. Next slide. One of the most important reports to come out recently out of my province, called In Plain Sight, was a recording of about 600 accounts of racism in the healthcare system. Our people were saying to us, and remember, I have about 1,000 staff who support 200,000 Indigenous people, approximately. We kept hearing from them, the system treats us terribly. The hospitals, in the hospital system, we get treated in a racist fashion, we get called names, we get ignored. And we're not imagining this. And there were so many accounts that we said, okay, well then let's collect those stories. And so here are some of them. It's a very slim document, like it's, I think, less than 100 pages. So if you can go in there, or if you want to go in there and hear the accounts, they're very banal, everyday accounts of the system and how it works. And inside of it, most importantly, there are recommendations about what we can do to fight racism within the system, especially within the hospital system. And I dare say, in spite of all of our investments and all of our work over these many years, our influence, our sway and influence, and maybe this is true here in public health, how much does our work in Indigenous public health affect the hospital system, if at all? Because people are still saying they're getting bad care. Next slide. We have a practice standard. We're trying to change the practice, the clinical practice, everyday work, clinical work of physicians and nurses and 25 other health professions. And so this practice standard from the College of Physicians and Surgeons of BC is very interesting idea. Just wanted to let you know that it exists. We can set an expectation. And in fact, we're talking about law, changing the laws in BC, requiring equity of service and equity of outcomes. Imagine if we had teeth where we had say, the law is for you to perform better. Not, wouldn't it be nice if you perform better and then, nothing changes and the staff keeps doing what they've always done. In fact, even defend the status quo. In fact, even defend how they currently work, even if you show them that our outcomes are awful. We can enact a practice standard and expectation, or even laws, laws around a requirement of equity of service and service access and equity of outcomes. Next slide. The UN Declaration on the Rights of Indigenous People is a requirement. It is a law in our province and in our country. It's sometimes called a duty to consult. So let's say you're mining or you're setting up a new hospital, you have a duty, a legal requirement to consult with local populations. You have to speak to them. You can't just show up and do what you want. You have to speak to local peoples and say, well, this is what I'm proposing. What do you think?
And is that in addition to like a certificate of need process that they have in the US?
I'm not sure what a certificate of need is, but
it's justifying that the service you're bringing in is needed. You're not just setting up shop, that you're not adding more beds when they don't need more beds, or you're not adding, you're not duplicating services. So you have to show that there's need to.
It sounds slightly different in that this is a duty to consult with those who have rights and title in the local area. So even if there is a need for a hospital, we still need to speak to the chief and their people and say, we're going to change your territory. What do you think? And honestly, the chiefs, I think, by and large, see the sense in cooperating. They're not going to say, oh, this is my land. I don't want your hospital here. Yeah. In fact, they'll say, yes, of course we need a hospital. Let's make a deal. Next slide. So we're finally getting to the meat of Indigenous public health. I would say that Indigenous people in Canada experience Canada and experience the public health system different from other Canadians. I would say that we come in last in almost every socioeconomic indicator, in every social determinant of health. We are the poorest of any ethnic group. We have the worst educational attainment of any ethnic group. We have the worst chances at meaningful work of any ethnic group, and on and on and on. We come in last in everything in our own territories, and that is not a fluke. That is in part by design. We were put in those positions in order to separate us from our lands. And so a public health system that doesn't acknowledge our colonial past or how we arrived here. And so for instance, someone saying to me, why do you live on a reserve? That's ridiculous. You would say, well, we didn't choose to live in segregated areas. We were put there. So don't put it on me how we live. You played a role in that. So if you expect me to do something about reserve conditions, then you have to do something about reserve conditions. Next slide. Some other considerations in indigenizing public health is around decolonizing the work so that it is less white-centered and more indigenous-centered, so that it takes into account the what I call the hangover from colonization. And colonization exists in in dozens of countries, at least 80 different countries, where original peoples are moved to the literal margins of their geography in order to make room for other peoples coming from other places. And the effects of that physical geographic disruption, those cultural dislocations, means that the original peoples are marginalized and impoverished and feeling the pressures of being stripped of what used to be their original resources. It's a very common experience, and we mustn't deny that reality in order to accomplish our goals in public health. Also, in public health, we need to acknowledge what can be dysfunctional relationships between us and them. So just a simple example, we're trying to collect Indigenous public health data, and the province, one of the provinces would say something like, well, we're not going to move on this until all of your chiefs are in agreement on how to do this Indigenous public health data collection and how that data is going to be stored and who will have access to it. Basically, they're saying we won't play until you all are organized enough and we're happy. It's really a we won't play. They're setting the condition for their involvement. They're saying no, hell with that, we're not doing it. It's just a polite way of doing it. And so that dysfunctional relationship is a part of it. It looks like neglect, and we say that to them. We say, you're not moving. You know what this looks like? It looks like an investment in our invisibility. You spend zero, you spend no time helping because it benefits you. And you get to sit around more, you get to save your resources, you get to not do a thing. You can sit there comfortably and not be uncomfortable and not have to work. It's exclusionary, it's white-centered, it's actually an aggression because our lack of equity, our lack of equality is immoral. It is immoral to allow families to live in poverty. It's immoral to allow people to pass away because they're of a specific race or color or ethnicity. Next slide. So some key public health themes that we've been talking about are around the colonial experience, around the social determinants of Indigenous health. They're different than the social determinants of health. I'll come back to that. We are married to our environments. In Hawaii, I heard Dr. Emmett Aluli and many others say we live in a beautiful paradise and we must love that environment, and we have kuriana, we have responsibility for our lands and territories and our waters. And we accept that responsibility. We act upon it. Issues like racism, issues like public health data, issues like communicable disease control and mental wellness, those are all part of public health, but they have a different spin when it comes to us. And there are, if we go to the next slide, the social determinants of Indigenous health. For us in Canada, this includes the residential school experience. You know, if there are 150,000 children who are now adults who went through the residential school system, we need to make allowances for them. We need to help them with their mental health and where they find themselves. We need to help them not be erased because some of them didn't make it and they're in unmarked graves. We must interact. So that's just around residential schools. And then there are things like self-determination. We should not be subjugated. We're looking at forced and coerced sterilization of Indigenous women. When I was being trained, I can't tell you how many obstetricians I would meet and who were my preceptors who would say, what are you going to do about Indigenous women being pregnant all the time? What are you going to do about that? And they would literally want to control Indigenous women's ability to have family or children. They had opinions about how this pregnancy should run, how many children they should be permitted to have. And sometimes they would interfere, like physically interfere and do surgeries that would reduce a woman's fecundity against her will. And so those impositions, those colonial hands all over our bodies are real. So self-determination, of course, is the right of the individual to determine their own course without interference by other individuals. Self-determination on a national level is the right of a nation to conduct its own business without being interfered with by another nation. Those are real parts of our lives that we must live with. And of course, language and culture. We've had tremendous pressures on our languages and our cultures. Erasure being the worst case scenario. And I know that all of our cultures here are facing a renaissance, but probably losses in those who speak their mother tongue, but increases in those who are learning our Indigenous language as a second language. And there are pressures on our spiritual beliefs, pressures on our knowledge of our kinships and our genealogies, to have our ancestors erased and taken away from us. We must push in public health against those. So imagine our genealogies as being part of our everyday work. How wonderful is that? I mean, I'm sure you would all celebrate with me if that was a part of it. And we'll keep going. And of course, our love of our environments. I come from a beautiful paradise, maybe not as beautiful as here, but I come from a beautiful paradise, and I will do my part in trying to protect it against what we call death by 1,000 cuts. Our environment is being chipped away at, not in a one huge cataclysm, but in little tiny ways every single day. A little piece here and a little piece there, little tiny incursions, trails that we used to walk and suddenly now we can't access, waterways that used to be pristine and now they're a little less pristine, parts of our territory falling out of our possession and into others or private possession, sacred places being desecrated, the quality of our plants and animals being reduced. The best way I've heard it described before is that, you know, we as humans are well protected from the degradation of our environment. We still have air conditioning, even in spite of global warming. We still have ways to purify water, even if our water is being contaminated in some way, shape, or form. There are ways to compensate for, you know, our lack of access to our beautiful territories. But really, we should be concerned about, you know, that the animals and the plants and the waters are suffering. That should be enough to trigger us, even if we're comfortable in our own homes. And we shouldn't have to be afraid, like in Phoenix. I was just in Phoenix, 40 degrees Celsius weather for weeks and weeks and weeks. If you break down in your car on the road, that could be life-threatening. We should not be in that position, like, oh, I'll do something about the environment. When I'm near death beside my car, we should not be in that position. Next slide. We have to find mastery over our own data. And data is not just an electronic set of digital recordings. Data is about our own bodies and minds and spirits. Data is about our literal children, and we should have possession, ownership, control. We need to keep thinking about this indigenous data about our flesh and blood and minds and spirits. Needs to be somewhat within our control. So how does that work? And it is complicated. It's complicated. Next slide. And we need to count ourselves in. I don't mean just count as far as data. I mean count yourself in. All of you here on the interweb, all of you here in the room with me, you're incredibly important. And that ascension into leadership, that being given authority over things that you should have authority over, don't be afraid to take that up, even though I feel like sometimes the colonial forces make us feel shy about stepping into spheres of control and influence. Next slide. So I think we're nearing our time. I'm going to skip mental wellness. We get a lot of time to talk about mental wellness, I think, in public health. Next slide. And we talk a lot about the dominant narrative, which is of us as the poor cousins of other people in Hawaii or other residents in Hawaii, or the residents of Hawaii how we're seen as the poor cousins of other peoples who might be in our territories. And our history is not well understood. It's not well learned. It's not well remembered by most people around us. And again, that word of whitewashing our realities. And in a way, it's understandable, but we must always buck against it and say, well, your simplistic understanding of who we are, okay. But please don't ask me to put aside my own identities and ideas and sophistication and genealogies and experiences and knowledges, because I won't. My knowledge is not the same as your opinion. Next slide. So Canada's had this Truth and Reconciliation Commission. Next slide. And my mother and father were part of that. They were asked to give their first person accounts of what happened to them in residential school. My father passed away, unfortunately, before he could give his statement to the National Archives. It's a terrible loss, but my mother, who went to residential school longer, is still with us, and she's agreed to give her testimony finally. And as someone who's in the therapeutic arts and never been able to get my mother to talk about what happened to her for 11 years, she spent 2 years in the hospital of that time in residential school. So her total time in residential school was only 11 years. Still never told me about it, except for the crushing loneliness that she said she felt, but not the actual physical experiences of what she had to endure. Next slide. And so, yes, I very much take my role as an intergenerational survivor very seriously. I will talk about residential schools because my parents won't be around forever to tell their first person accounts. And again, our family knowledge of residential schools is nothing compared to public opinion. It is not the same. I'm constantly bucking against that. Thanks. Next slide. And we have to deal with our sadness over what's come to pass. It's very real. You can imagine the discovery of so many thousands of children, our children. Sad. And next slide. And you can imagine the fury. The fury. Who does that? The tiny children. Who did that? What are their names? That's one of the questions we're asking. Instead of saying that just happened, we're saying, who did that? Which of you among us, which of your parents and your grandparents did this? And we started to ask that question. It's very painful. Next slide. So what has happened to our people has happened to us. It's so obvious and it's yet so important. We have inherited all of those stories that we watch in public health, all those people that we work with, and some of them have had a terrible time. That has happened to us as well. And so we must wear that and we must acknowledge that in order to continue coming back to work. Next slide. And we need to bring more than just our Western training. Wonderful that we are trained in public health and we have lots of experience, but we must also bring a great humanity. And thus again, the principles of Indigenous leadership. How do we endure and keep coming back to work? Next slide. It's partly about decolonizing and changing our ideas, our core values of what we think we're supposed to be doing and constantly questioning. And I hope today that I gave you a few things that will help you question. Next slide. One of them is to be humble about where we're working from and not be this, I work with doctors. We can be very self-important. Doctors, they're like people. And sometimes not enough humanity there, but to be humble, and that is to acknowledge I come from a very particular place, but also proud enough to say, where I come from is perfectly wonderful. But if we find ourselves diminishing and demeaning each other, we find ourselves disempowering others, which happens so often to our people, then we're in the wrong. Next slide. And so how do we live with Indigenous values of respect and understanding, accountability, equity, equality, balance, and having mechanisms to deal with rights and wrongs with appropriate and inappropriate actions? And I mean appropriate as in to give thanks, and inappropriate and to say to someone, what happened? What happened that 20,000 children died in your care? what happened that your hospital's outcomes for Indigenous people are so terrible and unchanging after years of work? Next slide. And so we want to create safe environments. We want to do no harm. Next slide. We want to be good allies. So I remember once helping a woman give birth, and I was teaching her how to push during her contraction, or in between contractions. I was saying, okay, now during your next contraction, here's how we're going to push. And she said, well, how do you know? And I said, well, she said, you've never done this like yourself. I said, no, my knowledge is vicarious. It's from being beside many women who've given birth. She said, okay, so you don't know. and my desire to mansplain childbirth to this laboring woman was very strong to say, I know stuff, I do know stuff. Learning to be a good ally is very hard for us to do. It's very humbling, but very important work, and one that I insist upon with my workers, that revisit your allyship again and again and again. And Joanne and I were talking about mahu and being a good ally and just having those. And I know that in my experience as a gay man, I came out in my teens, that those allies have sustained me through some very difficult times. And having an anti-racist stance, particularly around structural racism, can't tell you, even just this past week, I had a Black physician say to me, well, I've never experienced racism. And I wanted to say, but you're a man, and you're an older man, and you're a surgeon, and you come from, at least some kind of privilege. Please don't say racism exists, because racism against so many of us, and sexism and homophobia, exists for so many parts of the population, that using your voice to say, well, that's not my experience, is so naive. And so I wasn't talking about personal racism. I seldom talk about personal racism, and want to focus more on structural racism. Next slide. And this is an elder. And he said to me, I've been watching you. And he said, I know you're smart, but I want to see if you're strong in our way. And it was really a good lesson. Sometimes being smart is not that helpful. Sometimes being strong in our way is where it's at. Next slide. This is one of my beloved, and I feel like he was an example to me about how to be a warrior and a caregiver at once. We can be fierce and gentle and kind at once. You just have to see it, and you go, that is absolutely possible. Next slide. And just to wind us up, we're changing the name of my local town. This, I don't know if you can see, there's a pulp and paper mill in this photo. It's got like a smokestack. It's at the mouth of a river, and that's where our old village used to be. In 1910, we were moved to make way for that pulp and paper mill. It was named Powell River after one of the architects, Israel Powell, one of the architects of the residential school system, where so many of our people were hurt. He had never been to this area, but they still named that river, and they dammed that river, named it Powell River. And so we said to the local mayor, why don't you change the name of your town? I don't know why you're fond of the name Powell. He's never been here, and he was such a jerk. And why don't you change the name? Some of the townspeople really got up in arms. They really hated hearing non-English names in our territory. And of course, here in Hawaii, that's ridiculous. But it is a real thing. In South Africa, it's the same, as they change Afrikaans and English names to say Zulu names, or local names. People can feel very strongly about it. So that's happening at home, and it has caused quite a lot of consternation. Next slide. One of my elders reminding me that we need to be sensible in our work. Just keep going. That in our way, we know certain things, like grandparents contribute to children's well-being. This is an actual study. And I thought, oh, that's interesting. This is where we don't need to do research. We know that our grandparents play a role in our children's lives. Next slide. And one of the most important things I ever learned from my culture is around having been cursed, that maybe someone can curse you, but you have the power to heal yourself, call your spirit back, call your mind back, call your heart back, call your physical health back. So even if someone has hurt you, you have the power to heal, and that culture is healing, and that a traditional life is always better than a colonized one. And so many of the people we look after have terrible colonized lives, impoverished, inner city, homeless, lack of opportunity, lack of justice, lack of beauty. Those are colonized lives, and so we want to get away from that. Next slide. And it's really not about us, it's about the kids. Next slide, last one. And I hope I can remind us of the joy of where we're from, the joy of our people, the joy of how we were raised, what we grew up with, and in some of our cases, the pain of having missed some of that beauty while we grew up. But that our way is a way to embrace, and why would we put it aside? Yeah, why would we? Thanks so much. So thanks everyone out there for listening. If some of you are still there, I can't tell who's still there, but I feel really lucky to have had a chance to share with you some of the ideas from around our work on the west coast of BC in Canada. Thanks so much.
Thanks, Evan. Open it up for questions,
Yeah,
but can I ask first?
Oh, yeah, of course. Yeah.
Just one point of clarification. So I understand, and this is not typical, but the experience of some of the American Indian tribes too, that own land, right? So there's power in owning land, especially in America. So because the Salish groups never ceded land, is that why you're able to have the Indigenous health that space? I mean, it was not required, but it was politically just accepted, or
well,
how did that work?
This actually started from one of our premiers, one of our provincial leaders, not recognizing Indigenous rights and title, and he put out like a public vote. Do Indigenous people have inherent rights and title? It was a completely bogus vote because our rights and title are entrenched. It's actually in our constitution. And the chiefs were so angry at him. And of course, the public voted that we did not have inherent rights and title over our own territories. Those were extinguished according to the public. And we said, well, we don't care what the public thinks. You know, our land is our land. And if you don't want to play, then we won't play. And we said, then we won't cooperate. If you don't want to live together, then we will take our waterways back. We will not be involved in mining. We will not allow you access to our territories. We will grind your economy into the ground. If that's how you want to play, we will gladly do that. And very quickly, he came back and said, we will be an excellent neighbor and partner to Indigenous people. Really, that's the story. And you can look up that vote, and you can look up the sea change that came from that. And I'm surprised that Indigenous people in Canada don't use that more often. To say, you know, we're married. No one's going anywhere. You know, stop treating me like a second-class partner. Because I will show you, I'll burn this house down. As a word, I'll burn this house down if you want to push me on it. So it was, it really came out of politics. And so from there, we agreed, yeah, we're on this road together. We're treaty people. We walk together, but separate. And let's see what we can do if we're nice to each other. And some political dissidents have said, playing nicely with government, that it's a very bitter pill to swallow. And then others have, you know, have seen the benefit of our goodwill towards each other. So it's political, and that probably should be in the social determinants of health. Is political will. Absolutely, political will should be in there, or lack of political will.
I want to open it up to anybody else who wants to ask some questions. I know some of you submitted it in your registration, but I guess just speak up and we'll hear you. Any hands raised? There's one.
I'll go. If it's okay, just
Right.
Can you hear me okay?
Yes.
Yes, go ahead.
I'm really nervous because I'm a huge fan of yours. Sorry, I'm like super nervous. But I had a question I just have to ask. I am so impressed with the harm reduction materials and the Indigenous harm reduction materials that's come out of First Nation Health Authority. Like, it's totally changed how we look at harm reduction in Hawaii. I used to run the statewide syringe exchange and naloxone distribution program up until a couple of years ago. And we first came across your materials at an Indigenous harm reduction conference in Minnesota about 5 years ago. And seeing the materials that y'all put out about harm reduction and culture and drug use radically changed the materials that we've created here for outreach and understanding around harm reduction and drug use. So I just want to say that the amazing work from First Nation Health Authority. And I was just wondering if you had anything to say or comment about the harm reduction work that y'all are doing, because it seems so radical compared to a lot of health organizations.
Thanks. And our harm reduction responses are quite a big, long story. Partly that we had the data, we had real-time data showing us that opioid-related deaths were happening, and it was this tsunami of deaths that we noticed it so quickly. Second of all, that we had public health officials who were brave enough to sound the alarm and say, we know nobody cares. People have a lot of problems with people with substance abuse. Oh, you're using, what do you expect is going to happen? Of course, y'all are dying. But people could be really mean about it. And we decided that we would try and change it. We wanted to be evidence-based, so we tracked people to see what was helping and what was not helping. We defied the public because the public really was, they were saying things like, the government's going to be the new pusher. You're going to put out pharmaceutical grade heroin, for instance, so people don't overdose on toxic drugs. You're going to change the laws so that, simple possession doesn't incarcerate people, because the numbers of people who were going to jail were astronomical. And in case you didn't know, going to jail is terrible for your health. It's actually really, really bad for your physical health. And then just in Indian country, we had a lot of investments previously in drug and alcohol treatment centers, abstinence-based models, where we were asking people to quit. And we would speak to the chiefs and say, look, abstinence is great, but it is not for everyone. You can't get 100% of the people to 100% abstain 100% of the time. It is impossible, and people are dying. And so we need to change to at least some of the time, maybe a lot of the time, to harm reduction approaches. Last of all, our newest data is awful. In spite of all of that we've done, so much work. The death rate for Indigenous women due to the toxic drug crisis in BC is 11 times higher than other women. Our women are bearing the brunt. For the general public, the toxic drug crisis kills a lot of men. And that is not true for us as Indigenous people. And so what is that about? What is it about the lives of Indigenous women? And so for us in public health, we see this problem and we go, who's going to solve this? Who's going to lead this? And that's, I think, one of the core questions in public health is, who's going to lead this? So thanks for bringing that up. It is such a complicated question, and it's just utterly heartbreaking. I absolutely feel, hurt by those outcomes, and that we were spending so much time and energy only for things to still be going so terribly. But we're still at it. And our chief, I'm not the chief medical officer anymore. After COVID, I went to part-time, and now I'm working as an associate dean with the other part-time. But our new chief is an Indigenous psychiatrist, and she has a very good understanding and a very firm and able champion for or during the toxic drug crisis for our people. Thanks for the question.
Evan, what kind of impact on other areas outside of British Columbia, from the kinds of successes that you folks have had, or even lessons learned that you've had? I mean, do they, I'm not sure how Canada works, I'm so sorry, but do they, strength in numbers, right? Everybody's different, but there's strength in numbers. So are there times when you convene your allyship, for Indigenous issues and concerns across Canada?
Across Canada. There are times where the federal government tries to convene federal meetings. But there's such diversity, in the north, in the Arctic regions, very sparsely populated, but lots of resources. But there are Inuit people, the Eskimo people are different from the Indians. And then those of us living in the south, right on the border with the mainland United States, their lives are very different. And then we have weather. And then we have the vastness of, our cities are so far apart that national gatherings are incredibly expensive. We still attempt them, but I have to say our province is probably a little too inward looking. Like we know we're busy, we have lots of people, we have our own issues distinct to us, and so we're often inwardly focused and not nationally focused. I wish that would change. Having come from the federal government, I was there for 3 years. That's where I was redeployed for COVID, and I see some of the poorer provinces just doing terribly in this area, particularly in the plains of Canada, the Midwest of Canada. The Indigenous people are so impoverished with so few options. It's really quite heartbreaking to watch. At the very least, I hope our organization is comfortable with, we're doing some great work. We have some great investments, and we're absolutely willing to share. And so they will, like we're wealthy enough to spare me to go and speak in other places, to other jurisdictions. They allow me some discretion to do that. So yeah, I hope we can learn from each other. And that's why I think this kind of interchange between us is so important. I know for some people, they can be like, oh, what's Evan doing in Hawaii? And I say, well, we've agreed this is an incredibly important dialogue and interchange. And that's why I'm here, not because of, some silly optics. I mean, the information we share is real and important.
One of the things we faced with the Native Hawaiian Healthcare Act, which was kind of that wave where we had more specific data, we were asking for it, or sometimes creating it ourselves, was the response from our public health department that they needed to remain colorblind, right? And to address, that they even made it a color issue versus one of risk and where the communities were really hurting and in trouble. But it's not popular to say that anymore, but I can't say that they're not operating still in some of that thing, or even our universities for that matter. So, for those of you who are on the call today, Evan's going to be speaking with some of the medical students at 3 o'clock. It's the same link, I think, to tap in if you want to hear that conversation. But that one will look
Sorry.
that one will look at also Indigenous leadership, which I think is important. I mean, that's what we're fighting for. And I can't remember what exactly you were talking about, but the question that came to mind were some of the poor outcomes for hospitals. People don't look like us in the hospitals, right? They're not the doctors and people who understand the ways we seek health, or the way we process death, or the way, those kinds of things. So I made the assumption that probably that was the profile too.
Yeah, so for me, Indigenous leadership is not just about training us to be leaders, but to actually place us in places of authority. I feel like you probably know what needs changing, and you should be empowered to be able to do that and not have to go through other people in order to do it. Of course, there should be a process. Of course, there should be a way to discuss, what are we going to decide are the top issues we're going to tackle. But most of the time, it's really just about ascending into spheres of influence. For us, it really felt like we were applying to bureaucrats in Ottawa, 3,000 miles away, about what we should do for our own people, but we knew already. Just let us do it. And so once we were put in charge of ourselves, or more in charge of ourselves, we just went, and it's been very successful, and it makes, actually, now that we're on the other side of it, of course it makes sense. I mean, what would a bureaucrat in Ottawa know that's smarter than me? Why did we ever think that was a good way to make decisions? We know, we live here, and we've always lived here. So yeah, let us go. Anyway, I'll partly be talking about Indigenous leadership from other points of view, as in ascending, and I've already had people say ascending into authorities, positions of authority. It's maybe the wrong verb. There's another verb for.
Are there other questions on the comments, Kat?
Yes, we have from Misty. If you could please say your question.
Hi, can you guys hear me okay?
Yes.
Hi, my name is Misty Smith. I am I'll just read you my comment. Is there any, let's see, large aspects of Indigenous healthcare summits that is international? I've spent most of my time in healthcare in the Pacific Northwest and just recently moved back home to Hawaii. This is the first time I've been able to hear cross-Indigenous conversations about health disparities. And my background is neonatology. And I just moved back home a couple years ago and joined the Kapi'olani Medical Center for Women and Children in the NICU. And I really appreciate your time. I did work a lot with the Salish communities in Washington, so like Seattle area and Tacoma area. And this is the first time I'm just very happy that this conversation is happening, and I'm very appreciative for your time.
Thank you, and I hope we will continue to dialogue. And it has, I think we're far enough in our dialogue to see that it is tremendously fruitful in so many ways for us to cross-pollinate and to be in dialogue. And one of my favorite things to do is not just to lecture, but to have leadership converse with each other. So those plenaries where we each talk just a little bit about from our positions, but then you, the audience, get to listen to leaders talk about what they think is important. And it's important because it comes from experience. So I know I learned that in part in Hawaii by watching some of your kapuna in dialogue. I learned not from hearing them talk at me, but talk to each other, to be able to witness that. And that means us stopping and listening, right? And that's actually a very traditional way to transmit knowledge, to stop and to listen to the great ones, to the ones who are actually in charge, knowing that we are going to ascend into those positions soon enough. My dad would say, you're going to be in charge one day. You can count on that. And I think he meant it in the way of being the head of a family, but I think he was hinting that you could be in charge of a lot of things. And it sounds like you're in charge of a lot of things now, and I love that. I hope that you'll keep embracing that ascension and just really go. I really hope so.
Thanks for coming home, Misty.
Hello, yeah, it's definitely been an interesting transition. I think that across the world, really, we're all in different aspects of embracing each other, our cultures, but also to, as being a nurse practitioner in the Pacific Northwest, I actually had more access and ability to be more, right? As you say, ascension. But here, I'm hoping to be a part of the growth within our nurse practitioner PA ascension as well, just because, I think we just need to keep improving access, and sometimes different environments are not really welcome to that. And so I've just been dealing with my own adventures here, but I'm just trying to still work hard and make sure that, access is available for everyone, not just those that, change is good. Sometimes people are just afraid of change. And I think that I'm hopefully going to be a part of that change to help improve access to everyone here in Hawaii. And so it's great to be home. Thank you so much for that shout out. I actually got an invite randomly to this event. And so I'm very thankful that one of our doctors emailed it to me, and then I was able to be present. So mahalo.
Thank you. I'm so glad you were here too.
I cannot see this far.
Oh, Mahialani from the Kūkākūka, yes, I see your comment too. If you have any additional things to say.
Oh, mahalo nui. Thank you so much, Dr. Adams, for your talk today. I'm Mahialani Lam. I practice family medicine at Kiolomamo Native Hawaiian Healthcare System, and I'm also on the board for Ahahuia Kūkākūka. So very excited to meet you here. I just had a small comment, not really a question, but last week, the US Census Bureau released 2020 census population counts for detailed race and ethnic groups, including NHPI groups and AIAN tribes and villages. And just a brief look over the data, what was most disheartening to me was that less than half of our Native Hawaiian population lived not in Hawaii. And this is a number that's going down from the census 10 years ago. So I just thought that was so sad that all of our Hawaiians are being forced from their ancestral lands because of this public health crisis that we're in, probably that Hawaii is unlivable for many families, for our communities. So if there were similar situations that you've seen in your community and the populations that you've served, I think would appreciate any insights. I know it's a big problem when I see patients here and I hear their struggles. I'm just in my little hole trying to make healthcare more accessible, but I always go back to thinking how the greater environments here in Hawaii, how addressing the larger scale probably is where the solution is. So I'm very inspired by some of the things that you shared with us about on the systemic side, how some of these issues have been addressed in your community. Mahalo.
That's a really difficult and painful question, and I'm hoping there are places where that very question is being asked and not just being accepted. Oh well, we can't afford to live in our own territories. I know at home we talked about how to mitigate the lack of housing and lack of places to live. Like, how does our environment change? And we talked about, what if we could cure someone's cancer, but then we deliver them back to homelessness? Or what if we could cure cancer, but the actual biggest threat to our people was the loss of access to their own lands? Then we've been dealing with the wrong problem. So I'm hoping we're brave enough in public health to say, let's stop with, whatever that work was before, and let's, deal with the land issue. And of course, there are lots of really wrong-headed approaches to real estate that could be changed. And again, hoping that you all are ascending into the right places where you can influence some of those policies and laws that allow the continued loss of your lands and waters to others.
Yeah, that's a big pain point here for sure. Some of the real champions in Hawaii are our small nonprofits who really are just doing the work. They're addressing food insecurity. They're addressing more appropriate ways for seeking help and dealing with help. But they're not the ones who ever get it, right? It goes through this whole mechanism of, but I want to, sometimes I'm not against research. I get to do it, but you want to take a lot of those resources and just put it, why wait till it gets translated when people are already practicing it and know it and have been practicing it? So how do you move, or what's been successful in moving those resources more directly so that it does translate into real lived experience and work, and experts who are doing it, but they're not funded to do it. I'm watching people study what people are already doing and then moving back to the continent because it's just study for them.
Oh gosh. I know we all work in health, but for us, it felt like we were suddenly negotiators. Yeah. We were doing health negotiations, as in they were handing huge pieces of the health system back to us. And we were arranging for that, literally arranging for transfer of buildings and ambulances and nurses to our control. And how did that occur? So it wasn't just giving permission for them to come over to us, like for us to now be in charge of those resources and budgets. But how do we receive them? Like, what are we going to do with 300 nurses? Like, let's redeploy them. Let's change their job descriptions and what they do, the way that they're working now. We had to change their work culture. A lot of the nurses didn't know each other. A lot of the nurses working in our communities didn't know each other. They were all making it up themselves individually. We said, that sounds inefficient. Let's make them talk to each other, just as an example. And then, of course, redeploying and saying, gosh, we're spending a lot of time in research. Is that really our priority? Like, is research in the top 10? Is it in the top 100? And we had to reorganize all of our thinking about what the priorities were. And yeah, unfortunately, research was still at home is less important than some others, but I don't mind that because research is big business in lots of our partners, you know, especially universities, especially the ministry. Yeah, you know, they're still doing research. They can take care of that. And we even had to do things like, oh, Indigenous cancers, who's in charge of that? Are we going to be in charge of that? Are we going to build our own Indigenous Cancer Center? And we agreed the existing cancer center was good enough, but they needed to absolutely reform because they just weren't doing enough. And that was a big shakedown. Cancer Center said, we do all things cancer. We're really good at cancer. Who are you? All you brown people telling us what to do. And we said, yeah, we're telling you what to do. We're telling you, you're not good at this. And we had to admit, we're not good at cancer. That was hard. Them admitting they were bad at helping us, and us admitting we were bad at preventing cancer and getting our people in good opportunity. And really the best part of it was that we were in conversation after conversation, very rigorous, very time consuming, but at least we were in, because before there was nothing. Before the cancer agency was just doing its work, and we were just, I don't know what we were doing, but we weren't in the cancer journey reformation.
How did you get ready? So often, you know, we ask for things, but we're not ready yet. I mean, I think about like the back of the house stuff, right?
Yeah.
All the fiscal stuff. How do you transfer deeds and how do you?
I think you're ready.
Right? You're on that quick learning curve, right?
I think you just have to say we're ready, or
You're
or you have
ready.
to say, well, we're not ready, but it's happening, so we're gonna go. And my biggest job was to say, I've seen wards being run. You can run a ward, like it'll be fine. You'll see it's not that impossible. So like you all gird your loins because we're gonna be in charge of ourselves. Really, I spent a lot of time just cheering and saying we can do it, we can do it. I know it sounds crazy. You're gonna inherit all these staff, you're gonna inherit all these buildings, even just the fleet of vehicles. I was sitting there going, I'm not trained to deal with a fleet of vehicles. What am I gonna do with all those cars? But I will figure it out. Yeah. So I do think you're ready. I really do.
Well, are there questions? I'm gonna let everyone else know. I drove them around the parking lot so long. Lunch had to wait. I apologize for that.
Well, thank you all so much. It's just really been a pleasure.
Thank you. Thanks everybody for weighing in. Please write comments. I mean, you know, technology is on our side. Evan is accessible by Zoom. But the conversations are important to at least the work we do. I know the work that Hi-Fi does and Rose and I over at the university. You know, we don't have these conversations at many of the tables we have to bring it to the table. And so it's nice always having other perspectives and see where people are. You know, I like that attitude. Don't start me, I'll fight you.
Isn't it freeing just to say
Yes.
it?
But thank you. But look forward questions or ways that you want to stay in touch as well too. We're hoping that Evan's gonna maybe be in our space sometime next year. Yeah, so we're planning. So let's keep this going. I appreciate everybody who tuned in. If you want to tune into the 3 o'clock session, it's the same website. So I would welcome you to do that. Okay, thank you.
Thank you.
Everybody.
Take care.